So this is a rapid revision 5 days before exam. inshallah الجميع يكون موفق في الامتحان. And I will focus actually on the most important topics in the thyroid. If anyone want any question, please let me know. This is the most important things to revise in the next 5 days. Actual exam lab is very important. You need to revise all the questions of the exam lab. Also, the official website questions, you need to revise them. Also, a toolbox is important, but in the next 5 days, please revise the most important questions. Only don't waste your time in all the book. Also, most of last 5 years exam just a rapid revision. Guidelines, the most important guidelines to revise in the next 5 days is GBDS and NICE guidelines. Not all NICE guidelines, but at least the diabetes guidelines for GBDS and NICE. Oxford just rapid revision for the important topics. Just within 1 or 2 days you can revise all Oxford handbook, the 3rd edition. Don't waste your time in the 4th edition. Just revise from the source you study in the previous few months. And also, if you have some notes and algorithm, please revise them. And also the image is very important. Let's start. Actually, all of you, I hope all of you are ready for exam, but actually most of us ready for exam just before the exam by a few minutes. But I think anyone suggests that him is not ready today, so I will revise some of important things. Yes.
دكتور خالد، الاسئله بتاعت الامتحان الاوروبي دي هي نفسها، هي ال 20 بس الموجوده في الموقع دي ولا في اسئله ثانيه؟
Yes, the same question. Actually, the same question. I will. The same question. European board the same as SCE, the same questions, the same exam, but actually in this year the European board is cancelled. I don't know why. The next year no one knows if it will be appeared or not, but mostly it will be in the same time with SCE. So are you ready for the exam? Time management is very important because the exam is we have 2 sessions in the exam. Each one contain 100 questions and you need to be finished within 3 hours. So each question need to be solved within 1.8 minutes. And as mentioned by Dr. Ihab, the most important to solve 10 questions within 18 minutes. But I will suggest that you will, I hope everyone to try to solve 10 minutes within 15 minutes and you have 3 minutes to revise later on. So don't waste your time. If you don't know any question, please go to the another one and don't lose your time in one questions. And for example, if you see a question like this, please try in the first to read the head of the question to know that what he wants from the quiz. And some questions you can answer immediately without reading the scenario, and this is important to save some of your time. And if you don't know the correct answer from this answer, please try to exclude someone. Don't lose your time for more thinking about the correct one. Just remove some answers, some options from this, and if you don't know the exact answer, please choose anyone, the most important one, and flag this question to revise it later on. Don't waste your time in any question. If you don't know the exact answer or the correct answer, please choose any answer that you suggest it is the most accurate one and flag this question, and then go to the next question to save your time. And this is very important actually, and don't hesitate if you see some of the question at the beginning difficult question. This is not the same. Most of the questions are distributed very well. Some questions are very easy, some questions are intermediate, and some questions are very difficult, so don't hesitate. Yes. I don't know why this meeting will end in 10 minutes. If the session is ended, so we will continue and rejoin again. You are rapid. This is a rapid revision. Don't forget that a daily iodine requirement for adults is 150 microgram per day, and don't forget that a pregnant and lactating woman 250 microgram per day, because in a previous sources they mentioned that the pregnant and lactating woman daily requirement is 200. The correct one is 250 microgram per day, and this is updated WHO requirement. And the second, the most important topic, ratio of T4 to T3 are 15 to 1. If you see 20 to 1, choose it. If you see 13 to 1, all of them are correct, but the most accurate one is 15 to 1. And the most important in the exam, the iodinase enzyme type 1 and 2 and 3. This is very important, and in exams they usually ask about a tissue which represent which the iodinase enzyme in which tissue. For example, the iodinase 1 present mainly in the kidney and the liver, the iodinase 2 in the neuron, and D3 in the placenta. This is very important. And also they may ask about the iodinase enzyme responsible for conversion of T4 to T3 or reverse T3. This is very important. So T4 to T3 by the iodinase type 1 and D2, and to reverse T3 by the iodinase type 3, and this is very important. And actually propylthiouracil will block the iodinase type 1. This is very important. And also non-thyroidal illness will inactivate D1 and D2, not D3. And in non-thyroidal illness, reverse T3 will be elevated because the iodinase 1 and D2 is inactivated, so T3 will be decreased, T4 will be some sort to be normal or decreased, and the reverse T3 will be increased, and this is very important. And another very important subject, biotin assay interference. Biotin can interfere with thyroid function test, causing some of picture like hyperthyroidism. TSH will be decreased with elevated T4 and T3. This is a biotin assay interference. When you suspect biotin assay interference, if you see a symptomatic patient with thyroid function test similar to hyperthyroidism, and the patient take some sort of vitamins or some sort of over-the-counter drugs for healthy hair or for another indication. So biotin will cause thyroid function test like hyperthyroidism, but asymptomatic. No symptoms of hyperthyroidism, asymptomatic patient with a history of biotin ingestion. Another important topic is heparin that affects thyroid function test. Heparin will increase the free thyroid hormone with normal TSH, so it may be mimic central hyperthyroidism or resistant to thyroid hormone or TSHoma. So heparin, if any patient receive heparin, either low molecular weight heparin or unfractionated heparin, it will be like central hyperthyroidism. So don't forget this. Drugs that affect the thyroid function test is very important in the exam, but don't forget that amiodarone, with acute use of the amiodarone, will lead to mildly increase for TSH with elevation of free thyroid hormone, which mimic TSHoma or thyroid hormone resistance syndrome. This is within 3 months of ingestion of amiodarone, but later on, after 3 months, TSH will be normalized. So this is very important. After 3 months of intake of the amiodarone, TSH will be normalized. If TSH is elevated after 3 months, this is amiodarone-induced hypothyroidism. If TSH is low, this is amiodarone-induced thyrotoxicosis, and actually it is very important in the exam. how to differentiate between type 1 amiodarone-induced thyrotoxicosis and type 2, and depends on your diagnosis. The management is different. Amiodarone-induced thyrotoxicosis type 1 will be managed by carbimazole, but amiodarone-induced thyrotoxicosis type 2 will managed by corticosteroid. And this is a very important question in the exam. And usually there are two questions about the amiodarone. Lithium usually cause hypothyroidism, but in small percentage of patients will cause hyperthyroidism. But the most common of the lithium to cause hypothyroidism, elevation of the TSH with normal T3 and T4. This is the mimic hypothyroidism. Phenytoin, carbamazepine, valproic acid, all of them will decrease the thyroid hormone T3 and T4. So mimic central hypothyroidism with normal TSH. Heparin, we mentioned previously, will lead to elevation of free thyroid hormone with normal TSH. Don't forget that the corticosteroid, somatostatin, dopamine will lead to decreased TSH. So any patient receive corticosteroid, you must suspect that TSH will falsely low. Also, salicylate will lead to decrease free T4 and T3, mimic central hypothyroidism, and biotin will lead to picture-like primary hyperthyroidism. And estrogen, oral contraceptive pills, pregnancy will lead to increased TPG with increased total thyroid hormone, but not affect the free thyroid hormone or TSH. And this is very important. If you see a case scenario, TSH is normal, the free thyroid hormone is normal, with elevation of total thyroid hormone, you must suspect pregnancy or oral contraceptive pills, estrogen containing oral contraceptive pills. And if you don't lose your time in this big table, you can just take the summary: lithium, phenytoin, carbamazepine, heparin, and I must add biotin for them, because the biotin is in the recent few years, they love biotin assay interference. Another important topic, which is familial dysalbuminemic hyperthyroxanemia. This is to some extent mimic resistant to thyroid hormone. This is autosomal dominant condition, so there is usually a family history. Usually the free T4 is elevated with normal, in most cases, the free T3, but in some cases the free T3 will be elevated with normal TSH, and the gene responsible for it is albumin gene. So we can differentiate between familial dysalbuminemic hyperthyroxanemia versus resistance to thyroid hormone. In the resistance to thyroid hormone, there is usually elevation of the free T4 and the free T3 with normal or non-suppressed TSH, mildly elevated, and the patient usually symptomatic with mild goiter and mild symptoms of hyperthyroidism. So this is a very important topic. The half-life of some drugs in the exam is very important, so don't forget that the half-life of iodine 123 is 13 hours, and this is used usually for full thyroid scan and whole body scan. And radioactive iodine 131, this is a therapeutic drug and can be used for imaging in some of cases. Half-life of 8 days. And also a technetium, which is used mainly for thyroid scan, half-life is 6 hours. Gross hormone half-life is 20 to 30 minutes. Thyroxine 7 days. Don't forget this. Mesimazole and propylcyracil. Of course, we prefer mesimazole or carbimazole because it is less side effects. Mesimazole or carbimazole is preferred than the propylcyracil because it is a less side effects. It is more effective. It have a prolonged half-life, but the most important to use carbimazole because the side effects is less than the propylcyracil. Also, we use the propylcyracil in the first trimester. Why? Because it is less teratogenic. So in the first trimester, we use the propylcyracil because it is less teratogenic than carbimazole, but other conditions we use usually carbimazole or mesimazole because it is less side effects, especially in the liver, and all side effects is less with the carbimazole. So the half-life of methimazole is 6 to 8 hours. Don't forget that carbimazole is a prodrug converted in the liver to methimazole, and 10 milligram carbimazole is converted to 6 milligram methimazole, which is equivalent to 100 milligram propyltyrosine. And the half-life of hydrocortisone is 100 minutes, and dexamethasone is 36 hours. This half-life is very important, and if anyone have a half-life, so it is very important to collect them. In the exam, they will show a picture like this. Don't forget, this is Graves' disease. And this is toxic multinodular goiter. This is toxic adenoma. This is a hot nodule. This is one, and this is cold nodule. And in this situation, this is a thyroiditis or low radioactive iodine uptake, low uptake. What is the cause of low uptake? Any cause of thyroiditis, and also amiodarone-induced thyrotoxicose can cause low uptake. So don't forget this. And factitious thyrotoxicose. Another very important topic in the exam, which is U classification, which is published by British Thyroid Association in 2014, and they usually ask what about benign feature of thyroid nodule or malignant feature. So don't forget that peripheral vascularity is a benign feature, intranodular vascularity is a malignant feature. This is very important. Peripheral eggshell calcification is a benign feature, and even if the eggshell calcification without any, in other words, this is a benign feature. But if they ask about disrupted peripheral calcification, this is a malignant or suspicious feature. And they usually put a microcalcification, which is a malignant feature, and taller than wide shape is a malignant feature. And if there is associated suspicious lymph node, this is a malignant feature. So a suspicious and malignant feature, lobulated outline, microcalcification, intranodular vascularity, taller than wider, associated suspicious lymph node. And a benign feature, peripheral eggshell calcification and peripheral vascularity, or a pure cystic or spongiform, this is a benign feature. Microcystic spongiform is a benign feature. And after that, according to the U classification, U1, U2, U1 is a normal thyroid, U2 is a benign thyroid nodule, U3 is intermediate, U4 is a suspicious nodule, U5 is a malignant nodule. In each one of them, U1 and U2, no need for fine needle aspiration biopsy except if there is a high suspicious of malignant thyroid nodule. For example, if you see U2 in the exam, don't choose fine needle aspiration biopsy if they put in the question or scenario there is no alarming manifestation, no family history of thyroid malignancy, no any alarming manifestation of thyroid malignancy. So in this situation, reassure and disassure. But if they present you two, but in the scenario there is a family history of thyroid cancer, you should go to fine needle aspiration biopsy. If they show you two, but there is a micro, if they mention microcalcification, so this is not U2, this is a U5 actually. But if they mention that there is rapidly growing thyroid nodule and U2, in this situation, you should go to fine needle aspiration biopsy and so on. But in U3 to U5, you should go to fine needle aspiration biopsy. So in U1 and U2, no follow-up required except in some situation with U2. But in the case of U3 to U5, you should go to fine needle aspiration cytology. And according to the fine needle aspiration cytology, this is very important in the exam. They will ask about a description of the Psi1, Psi2, Psi3, Psi4, and Psi5. They will ask about the description of this Psi, and they will ask about the action for this Psi. Don't forget that Psi1, this is non-diagnostic, and the action you should do is repeat fine needle aspiration biopsy under ultrasonographic assessment. If they Psi1C, this is assessed, so we should correlate with clinical ultrasonographic finding. Psi1C, this is a cystic nodule. Psi2, this is a non-neoplastic lesion, and in this situation correlate with clinical and ultrasonographic finding, and in most cases if intermediate risk or suspicious feature in the Cy2, we should repeat fine needle aspiration cytology within 3 to 6 months. So don't forget that Cy2 usually no need to repeat fine needle aspiration biopsy except if there is a suspicious finding. Suspicious finding, like for example by ultrasonography U3 or U4 or U5, or there is a family history of thyroid cancer or previous nickel radiation, and so on. So Cy2 like Q2, we need to repeat fine needle aspiration cytology if there is a suspicious feature, but in this situation in the Cy2 we should repeat after 3 to 6 months, but with the U2 we can repeat it immediately. So this is very important. But in Cy3A atypia, if follicular neoplasia, don't forget this, if not follicular adenoma or carcinoma, this is a follicular neoplasia. So if you see Cy3F, the action we should do hemithyroidectomy or lobectomy. And if it reveal differentiate thyroid cancer, the next step is to do completion thyroidectomy if malignant, because the risk of malignancy with Cy3F is 10 to 40% risk of malignancy. Cy3A, this is atypical, and in this situation we need to repeat fine needle aspiration cytology and discussion as thyroid cancer MDT. Cy4, this is a suspicious of malignancy, and in this situation we do diagnostic hemithyroidectomy because the risk of malignancy is 70%. So Cy3F and Cy4, the management of it is diagnostic lobectomy, but Cy5, this is a diagnosis of malignancy, and in this situation we should do surgical excision, not lobectomy, but do total thyroidectomy for differentiate thyroid cancer. And we should go to the radiotherapy or chemotherapy for anaplastic thyroid cancer. But don't forget that in anaplastic thyroid cancer, the ideal management of it is thyroidectomy, surgery. But the most case of anaplastic thyroid cancer came late. Surgery is not candidate for this patient, so radiotherapy and chemotherapy is the most available treatment for anaplastic thyroid cancer. And also lymphoma, the treatment is chemo or radiotherapy. This actually Cy classification is very important, and what is the next step is very important. And the risk of malignancy, don't forget that Cy3, the risk of malignancy is about 10 to 40, Cy4 70, Cy5 is about 95, Cy1 like the general any thyroid lesion 5 to 8, and Cy2 the risk of malignancy is less than 3, and this is important in the exam. And also another important topic in the exam, when to refer a patient with thyroid lump. And actually don't forget that if there is a presence of stridor, we should refer this patient immediately. But if there is unexplained hoarseness or suspicious cervical lymph node or thyroid nodule in a child or rapidly enlarging within weeks, painless thyroid mass, we should refer it urgently, which means within 2 weeks. But if there is abnormal thyroid function test, for example, TSH is low with low thyroid hormone, in this situation we refer the case to endocrinologist within non-urgently. If there is a sudden onset of pain in the thyroid lump, this is a hemorrhage in the thyroid lump, we need to refer it non-urgently. Also, gradual enlarging thyroid nodule over months, need to refer it non-urgently. But the most important, when to manage in a primary care, no need to refer if there is a thyroid lump or goiter which remain unchanged in the size. So any thyroid nodule stationary course within, for example, 20 years, leave it alone. Don't do fine needle aspiration biopsy. No need to treat it as no change in the size or no alarming manifestation. Non-palpable thyroid nodule, just incidentally nodule less than 1 centimeter, should be managed in the primary care unit. Non-thyroidal illness is important in the exam, and they will ask deactivation of D1 and D2, which is responsible for conversion of T4 to T3, and the reverse T3 will increase due to the non-normal deiodinase type 3. If option inactivation of D1 is not available in the exam, in the options, you can choose activation of D3, which is not very common in the recent exam. Also, important hint about non-thyroidal illness, TSH will be low. This is the first thyroid function test to be affected in the non-thyroidal illness. After that, reverse T3 will be elevated with low T3. So TSH will, the first thyroid hormone will be affected in non-thyroidal illness. And lowering of the T3 and elevation of reverse T3 will correlate with severity of the illness. So don't forget this in any patient in the intensive care. This is a non-thyroidal illness syndrome in most of the cases, or the patient already on the dopamine, or which will affect TSH, or also intake heparin, which may affect the free thyroid hormone, leading to elevation of thyroid hormone. When you suspect assay interference, if there is a discrepancy between clinical feature and the biochemical results. For example, if you see any case of elevation of thyroid hormone with non-suppressed TSH and asymptomatic and no manifestation of TSH trauma or resistance to thyroid hormone, in this situation you should choose assay interference. Even if you don't know what is the assay interference in this scenario, but assay interference is more common than TSH trauma. Assay interference is more common than thyroid hormone resistance syndrome. And also macro TSH and heterophil antibodies, this is a types of assay interference usually leading to elevation of the TSH. And also, if you see a case with elevated of the TSH and you give thyroxine and the TSH not normalized, in spite of the free thyroid hormone is elevated, you must suspect assay interference in this scenario, like macro TSH or heterophil antibody. But the most important in this scenario, if you give thyroxine and the TSH is still normal, is still elevated, with the thyroid hormone is elevated, non-compliance is the first choice in this scenario. So in any patient with hypothyroidism and you give thyroxine and the TSH is still elevated with elevation of or normalization of thyroid hormone, the first you must suspect non-compliance with thyroxine. And if non-compliance is excluded in this situation, macro TSH is another option, or heterophil antibody is another option, which is a types of assay interference. And as we mentioned previously, biotin is give a similar like primary hyperthyroidism. So thyroid function test should be repeated from a different laboratory using a different assay method if you suspect assay interference. Another important and maybe presented in some previous exam, HALA, DR, and the thyroid, and another endocrinological disorder, autoimmune endocrinological disorder. So don't forget with the type 1 diabetes, HALA, DR3 and 4, DR5 with Hashimoto thyroiditis, DR3 with Graves' disease and Addison and systemic lupus, and B35 with De Quervain thyroiditis. So the most important, DR3 with diabetes and Graves' disease, and B35 with De Quervain thyroiditis. All of these disorders are autoimmune disorder. And this is pretibial myxedema, and don't forget or miss it or diagnose it as a necrobiose lipidica like this, because in each exam they will give a picture of necrobiose lipidica. And actually the treatment of necrobiose lipidica usually is supportive treatment. The corticosteroid is not very important except in some of little conditions. So the follow-up is most important one. Even control of hyperglycemia has no relation between appearance of necrobiose lipidica. And another very important topic in the exam is drugs that you anti-thyroid medication. And as we mentioned previously, carbimazole is the first choice in any patient need anti-thyroid medication except two conditions. Why we choose carbimazole? Because it is less side effects than propyltyrosine. Why propyltyrosine is not first choice? Because side effects is more. Never use the propyltyrosine in the children or adults or any population except the first trimester because it is less teratogenic, and also in the thyrotoxic storm because it leads to blocking of the adenase type 1, which is responsible for conversion of the T4 to T3, so will lead to decrease thyroid hormone action in the tissues. So the propyltyrosine is used usually in the first trimester and in the thyrotoxic storm. And during the pregnancy, the propyltyrosine is used because it is less teratogenic. The mechanism of action of anti-thyroid drug carbimazole and propyltyrosine or methimazole, usually in the exam they will ask a question like this. It will lead to intrathyroidal inhibition of iodine oxidation, organification, iodotyrosine coupling, thyroglobulin biosynthesis, follicular cell growth. It inhibits the peroxidase enzyme. So once you see TPO, so choose this option in the exam. It will inhibit the peroxidase enzyme, which is responsible for oxidation, organification, coupling, thyroglobulin biosynthesis, and also will inhibit the follicular cell growth. And another indication for propyltyrosine mechanism of action, it will inhibit the iodinase type 1, which is responsible for conversion of T4 to T3 extrathyroidal tissues. And this is very important. And another one is very important is side effects of anti-thyroid drugs. This is very important actually. In all the exams they will ask a question about this. Granulocytosis, the incidence of a granulocytosis, it is 1 to 5 per 1,000 population. 1 to 5 per 1,000 population or patients. So don't forget this. So in the exam, if they ask a percentage like 1 to 500, this is a correct one. If they 2 in 1,000 people, this is a correct, and so on. So don't forget a granulocytosis, the incidence of a granulocytosis 1 to 5 per 1,000 population. And a granulocytosis have a gross reactivity between carbimazole and the propyltyrosine. So if it occurs with the carbimazole, don't give a propyltyrosine and vice versa. And this is usually occur in the first 3 months of treatment, but it may occur later on. And this actually occur very suddenly. So the follow-up with the CBC is not a correct answer in any exam. No need for monitoring by CBC. Once the patient is presented by fever or sore throat and receiving anti-thyroid drug, the first step, the next immediate step is stop the anti-thyroid drug and doing CBC. So any patient presented with fever or sore throat or evidence of infection, you must immediately stop carbimazole or propyltyrosine and do CBC. If it's CBC just leukopenia, so you can recontinue the medication. If granulocyte is less than 500 per cubic millimeter, this is a granulocytosis. So a granulocytosis means a granulocyte is less than 500 per cubic millimeter. So if a granulocyte is, for example, 600, this is not a granulocytosis and you can continue anti-thyroid drug. And another side effects of anti-thyroid drug is allergic type reaction, rash, urticaria, arthralgia, and this is usually mild, and this usually don't necessitate stopping the medication, just give antihistaminic drug. And if it is severe with carbimazole, we can convert the patient to propyltyrosine, and if the patient on propyltyrosine, we can convert it to carbimazole. Another very important in the exam is the incidence of liver cell failure with the anti-thyroid medication. This is usually 1 to 10,000 the incidence of liver cell failure with propyltyrosine. propylsulfonyl leading to liver cell failure, and the incidence of liver cell failure is 1 to 10,000 population, but in the children it is 1 to 1,000 population, and in the previous exam they ask a question like this. The duration of the therapy of, for Graves' disease, don't forget that medical therapy today is the first choice in any patient with presented by Graves' disease, but there is some trend to go to the radio iodine ablation as a first choice late, not in this exam, but in the next few days, a few years. Actually, in the USA, radioactive iodine ablation is the first choice, but in the other countries, medical treatment is the first choice. But there is some trends in most of countries to let it prior to medication, because a risk of relapse after antithyroid drug is more than 50%. It is 40 to 60% risk of relapse after medical therapy after treatment of adults for duration of 18 months. Don't forget the treatment for children is 36 months. Why? Because the risk of relapse in children is more and more than adults. Risk of relapse in adults is about 60%, but in children it is more than 95%. So after this duration, if the patient cannot tolerate drugs or non-compliance or personal decision, we can go to radioactive iodine if the goiter is small and no active Graves or propathy, but surgery is preferred if there is a nodule or a goiter is more than 50 milli, or there is active Graves or propathy, or the patient seeking fertility within the next few months. So surgery is preferred in a young female if they seek fertility within the next few months. If the Graves disease is persistent after this duration, we should do TSH receptor antibody. If it is positive, we can continue methimazole for another 12 years, or go to the definitive treatment by radioactive iodine or surgery, or long-term low-dose methimazole, 5 to 10 milligram of methimazole for long duration. But don't forget, this option is not suitable for young females. And after another duration of methimazole, 12 months of methimazole, we should go to check TSH receptor antibody. If it is negative, we can stop methimazole and reassess our case. If it is positive, we should go to the definitive treatment by radioactive iodine or surgery or long-term drug. Relapse the same as persistent hyperthyroidism, we can go to definitive treatment or long-term low-dose methimazole after stopping long-thyroid medication. A risk of relapse is elevated in the younger people, less than 40 years, in the younger and in the male gender. And of course, all of us know that smoking and large goiter or patopathy, elevation of the free thyroid hormone or positive TSH receptor antibody or thyrotropin binding inhibitor immunoglobulin, this is the same as TSH receptor antibody. If it is positive, risk of relapse is higher. But the most important to memorize, a younger age risk of relapse is elevated, in male gender risk of relapse is elevated. Smoking, large goiter or patopathy, high thyroid hormone, TSH receptor antibody positive. This is all of us know that. Radioactive iodine ablation is very important in the exam, and usually response to radioactive iodine success rate is about 85%. So about 15% of the population require a second dose. And if you decide the second dose, don't consider it, usually consider at least 6 months after the first dose to be sure that the first dose is effective. And also childbearing pregnancy, avoid pregnancy for a minimum of 6 months following a radioactive iodine ablation, and this actually for male and female. In the Oxford Handbook, these are both editions. They mention that men should avoid fathering children for 4 months and the female 6 months, but actually in the guidelines published by the ETA, European Thyroid Association guidelines, they mention that avoid pregnancy for 6 months for both male and female. So in the exam, they may mention like this 4 to 6 months, for example. So choose this age. If they mentioned 4 and another option 6, choose 6. And actually, the prevalence of hypothyroidism after radioactive iodine is about 50% after 10 years, and the prevalence is 80% after 25 years of radioactive iodine ablation. So the success rate of radioactive iodine is 80%. The relapse after antithyroid drug is 40 to 60%. The dosage of radioiodine ablation usually for grave disease is 500. Don't forget this is a megabecquerel, and for grave for toxic adenoma is 500. For grave disease 4 to 600. For toxic multinodular is 4 to 5 to 800 megabecquerel. So this number is important, and usually 500 in most of these conditions. And before giving radioactive iodine ablation, we should stopping antithyroid drug for 2 to 7 days, and we can restart this antithyroid drug after commencing radioactive iodine by 3 to 7 days after radioiodine. And don't forget that levothyracil has a prolonged radioprotective effect, leading to resistance to radioactive iodine ablation. So it should be stopped 2 to 7 days before radioactive iodine ablation. Don't forget that a radioactive iodine ablation, a radioactive iodine 131, is given orally, and no universal agreement regarding optimal dose, and in most cases we use 400 to 800 megabecquerel. And if there is a failure of the first dose, we increase the dose in the second sessions after 6 to 12 months after the first dose. And the outcome of radioactive iodine, as we mentioned previously, 50 to 70% of the patient will restore normal thyroid within 6 to 8 months. The shrinkage of the goiter takes a very long time, and the shrinkage of the goiter will be reduced by 50% after 1 year, and this is very important. And actually, this is a question in a previous exam. Instruction to a patient after treatment is very important, but it is very difficult to understand how the question will be presented in the exam, because options are very long, and so don't forget that in most cases avoidance depends upon mainly a dosage of radioactive iodine. So with long dose, we need to avoid some things for a long duration. So don't forget, this is very important. Don't forget that we need to avoid journey on the public transport if we have received a very high dose of radioactive iodine only. Avoid the place of internment or close contact with people depends upon the dosage, and so on. Avoid stay off work which involve close contact with other people like pregnant female and children in all dosage, but if in a high dose we should avoid it for a prolonged time. So if these precautions cannot be followed, so radioactive iodine in this situation is not suitable for this patient. So this is very important. If a case scenario have a patient, female patient, and cannot avoid pregnant female sister in the same place, in this situation, radioactive iodine ablation as a treatment is not suitable for this female. Another important question in the thyroid storm, alternation in the mental status is very important. Delirium, for example, delirium is more superior than the fever per se. And this how to treat thyrotoxic crisis or storm. Propyl sauracil is preferred than carbimazole, but in very high dose, because propyl sauracil inhibit the activation of D1 to D1, inhibit the conversion of T4 to T3 by inhibition of the iodinase type 1. Also, we give some drugs that inhibit the thyroid hormone release, like potassium iodide, Lugol's iodide, lithium. So الميكانيزم of action of Lugol's iodide or potassium iodide inhibit الهرمون release and inhibit organification. And of course, before giving propyl sauracil and potassium iodide, we should give beta adrenergic blocking drug to decrease tachycardia and so on. Subclinical hyperthyroidism in the exam is very important. It is diagnosed by persistent low TSH with normal thyroid hormone and can be classified into two types, type grade 1 and grade 2, according to the TSH level. If TSH is less than 0.1 and another one grade 1 low TSH 0.1 to 0.4 no less than normal, mildly low TSH, this is grade 1. TSH less than 0.1, this is grade 2 or severe subclinical hyperthyroidism. We should repeat thyroid function test within 2 to 6 months for patient with high risk, or within 3 to 6 months if there is no risk factor. When to manage according to the age and the grade and the risk factor. If the age more than 65, we should treat. If TSH is less than 0.1, not 0. This is wrong in the Oxford Atoll book. This is wrong. Actually, TSH is less than 0.1, not 0.01. This is not correct. And this 0.1, not 0.01. So I try to correct it from Atoll book. And this is actually from the guidelines published by the American Thyroid Association, the same table. So if the age is more than 65, this is an indication for treatment. If the age is less than 65 with heart disease or osteoporosis, this is an indication for treatment. If the patient is less than 65 and symptomatic, we should treat. But if the patient is less than age is less than 65 and asymptomatic, we should observe. Except if TSH is less than 0.1, in this situation we can consider treatment. So treatment of subclinical hyperthyroidism depends on the age, TSH level, and another comorbidities. Heart disease, osteoporosis, treat. Even any type of subclinical hyperthyroidism, any age you should treat. If there is a heart disease or osteoporosis. If the patient is asymptomatic and the age is more than 65, we should treat. If the age is less than 65 and asymptomatic, we consider treatment only if TSH is less than 0.1, severe subclinical hyperthyroidism or grade 2 subclinical hyperthyroidism. Thyrotoxic hypokalemic periodic paralysis is a patient presented by thyrotoxicosis with painless muscle weakness. Sudden attack of painless muscle weakness, some sudden attack of the paralysis. Usually this will be aggravated by carbohydrate intake or cold weather or insulin or vigorous exercise. How to treat? Give potassium replacement therapy and treat thyrotoxicosis by antithyroid drug. This is usually will improve within 2 to 4 hours and full resolution within 1 to 2 days. The age of the onset is 20 to 40 years, more common in the male and Asian population. This is improved once thyrotoxicosis is treated, but we should treat by potassium because the patient presented mainly by hypokalemia, thyrotoxic hypokalemic periodic paralysis. Thyroid disorders during the pregnancy and the lactation is very important, and I want to know, all of you know that TSH is not passing the placenta. TSH cannot, TSH of the mother cannot pass through the placenta, so cannot affect the patient, the fetus. الثيروكسين.
Khalid,
Yes.
do we need to do a thyroid scan in case of thyroid toxic periodic paralysis?
If you cannot diagnose thyrotoxicose with thyroid autoantibody, you can do thyroid scan. But actually, if you suspect underlying grave disease, it is best to do TSH receptor antibody. But if it is unavailable, so thyroid scan is alternative method to diagnose a grave disease usually. So if in any case, if a Graves disease can diagnosed by lab, so no need to do thyroid scan. If you can not diagnose or reveal the etiology with the thyroid autoantibody, so the thyroid scan can be differentiated between Graves disease and other cause of thyrotoxicosis.
Okay, yeah. Thank you.
So, so levothyroxine passes through the placenta and can affect the fetus thyroid. TSH receptor antibody pass the placenta and can predict neonatal thyrotoxicosis. Iodine pass the placenta and can affect the thyroid status. Radioactive iodine pass the placenta and can distract the fetal thyroid gland, so it is a contraindication to do thyroid scan or radioactive iodine for a pregnant female. Propylserostil and mesimazole both drugs pass the placenta and both drugs are teratogenic, but propylserostil is less teratogenic than mesimazole. Propranolol pass the placenta and it is not preferred, but it is the safest beta blocker to be used during the pregnancy. And if you need a beta blocker during the pregnancy, we can use propranolol safety during the pregnancy, but for short duration. And this is very important because if the patient presented by Graves disease during the pregnancy, we can give propranolol during the pregnancy. المانجمنت of Graves disease in the mother, aim of treatment decreases.
معلش لابيتالول sorry
Yes.
لابيتالول or propranolol, what is the more preferred in pregnancy?
Propranolol.
Not labetalol.
Yes, labetalol is safe. Labetalol is safe, but here we need to give drugs that mainly act on the beta 1. Labetalol is beta and alpha. Okay. Labetalol usually in the case of fake chromocytoma and safe during the pregnancy, but here as a beta blocker, the most studied beta blocker with Graves disease is propranolol. Beta blocker in the treatment of thyrotoxicosis, and here they mentioned that preferred agent for pregnant and lactating female. This is from the guidelines, the American guidelines, the propranolol. And also atenolol avoided during the pregnancy. Labetalol is not mentioned as a beta blocker that can be used in the treatment of thyrotoxicosis actually in the guideline. So propranolol is the most preferred agent for nursing and the pregnant mother.
And British it can be.
Abdel Qadir said that both can be given in pregnancy according to the British Medical Journal. But I want to know that Dr. Omar in the Graves disease or another indication. I know that labetalol is safe during the pregnancy. Actually, in the preeclampsia, the first drug is alpha methyl dopa, and labetalol is very safe. But it is mentioned that it can be used in the Graves. He mentioned, Dr. Omar, labetalol can be used in Graves disease during the pregnancy as mentioned by British Medical Journal. Okay, Dr. Omar. Thanks, Dr. Omar. So the most important that block and replace regimen is not suitable for during the pregnancy. And if you see question like this, hyperthyroidism on a block and replace got pregnant, what to do? The first one is to stopping levothyroxine and to reduce the carbimazole dose. And actually, if in the first trimester, I will convert the carbimazole to propyltyrosine. Yes, also, yes. Metoprolol also safe in pregnancy as mentioned by someone. So, but usually the dosage of carbimazole during the pregnancy, it is preferred to be the least dose of carbimazole. They recommend it be less than 15 milligram per day during the pregnancy. And both drugs are teratogenic, but the carbimazole is more teratogenic than the propyltyrosine. The propyltyrosine give malformation in the face and neck. And don't forget that the carbimazole give aplasia cutis and omphalocele, esophageal atresia, and gonadal atresia. So propyltyrosine should only be prescribed in the first trimester, and we need to check liver function test monthly. Propranolol, yes.
You mentioned the previous session that if the patient on carbimazole, we should continue on carbimazole.
Yes, I will show it because this is a recent update in the 4th edition, but actually in the exam, did we will follow this recommendation or not? I don't know actually. I will show it later within a few slides. And as we mentioned that propranolol, we should use it for a few weeks only during the pregnancy, and even in management of any grave disease, beta blocker is used just for a few weeks. And the dosage of antithyroid drug should be adjusted according to the free thyroid hormone, not TSH. We should keep the free thyroid hormone in the upper third of the normal. And don't forget that iodide and radioiodine is contraindicated during the pregnancy. Surgery if done in the trimester. Breastfeeding is allowed. The dosage of carbimazole should be less than 30 milligram per day to be safe for breastfeeding female. And it is preferred to divide the dose of carbimazole into separate dosage per day. Pre-pregnancy counseling, they recommend should attain euthyroidism before getting pregnancy, because uncontrolled hyperthyroidism will increase the risk of miscarriage, delivery, stillbirth, low birth weight, congenital anomalies like synostosis. And as we mentioned, if the patient received radioiodine ablation, should not get pregnant within 6 months. And of course, most of the patient antithyroid drug medication require usually decrease during the gestation, and about 50% of the patient required cessation of carbimazole in the last trimester. When to screen or whom to screen for thyroid disorder during the pregnancy, no consensus of the opinion, the routine screening, but we should screen females with high risk group. High risk pregnant female to presented with thyroid disorder if the age is more than 30 years, if there is a family history, if there is a goiter, if positive anti-TPO, if presence of another autoimmune disorder like type 1 diabetes, if there is infertility, miscarriage, previous radiation, iodine deficient area, morbid obesity. In this situation, we should screen for thyroid function test with a new pregnancy. Thyroid hormone resistance syndrome, this is very important in the exam. They usually presented by a patient presented by elevation of both free T4 and T3. T4 and T3, not T4 alone. So T4 and T3 must be elevated with non-suppressed TSH. Patient present usually with goiter, short stature, hyperactivity, attention deficit, learning disability, and the responsible gene is thyroid hormone beta G. And the most important test is intact TSH responsive to TRH, and no treatment is required usually. How to differentiate between thyroid hormone resistance syndrome with SHOMA is very important. Don't forget that resistance to thyroid hormone resistance is presented in there is a family history, And the TSH response to TRH in the TSH a blunt response, but here will be increased as normal. The TSH response to T3, if we inject T3 or thyroxine, the TSH will be decreased in the thyroid hormone resistance like in normal individual, but not change in the TSH. The TSH will be increased with resistance to thyroid hormone if we inject TRH, but with the TSH not change. The alpha subunit is very important because it will be increased in TSH, not in resistance to thyroid hormone. The pituitary MRI, in most of cases of TSH macroadenoma, size is more than 1 centimeter, but resistant to thyroid hormone is normal or incidental pituitary adenoma, non-functioning pituitary adenoma. So in the exam they will mention the best biochemical test is an elevated alpha subunit. If in the exam they ask to differentiate between TSH and resistant and they give alpha subunit and pituitary MRI, choose alpha subunit. After that, a TSH responsive to TRH blunt response, TSH response to T3 not changing the TSH decrease with resistance to thyroid hormone. MRI will show macroadenoma in the TSH. How to treat? The best management of TSH is surgery. But preparation of the surgery need to give somatostatin analog, not antithyroid medication. And this is very important because in the question in the toolbook they answered 8 antithyroid medication, but if you read the comment you will reveal that this is incorrectly. The best answer is to give somatostatin analog before the surgery, but the surgery is the best option for treatment for TSH. Even after surgery, the cure rate is less than 1/3 of the patient, but still surgery is the best option for the management of the TSH. After failure of the surgery, the next option is to give somatostatin analog, either octreotide or lanreotide. This is not very important. And of course, drug therapy is useful in the pre-operative preparation. So radiotherapy is useful following unsuccessful surgery and lead to gradual over years. The radiotherapy needs over years to reduce the TSH. So radiotherapy is not ideally treatment for or the first option. The first option is surgery. The second one somatostatin. The third one is radiotherapy. The antithyroid drug is not the correct one because it leads to elevation of the TSH and increase the size of the tumor. The treatment of active orbitopathy or Graves orbitopathy is very important, and actually don't forget that the high dose of corticosteroid is still the main corner for treatment of active Graves orbitopathy. But in the latest guidelines and Oxford, the 4th edition, they mention that intravenous glucocorticoid pulse therapy has advantage over the oral corticosteroid. So, the intravenous corticosteroid is the first choice for management of active orbitopathy. And in this situation, with high dose of corticosteroid, we should monitor the liver function test. And we should give proton pump inhibitor and bisphosphonate if we give it for a long duration. Adverse effect is commoner with oral intake and can lead to liver failure, so we should assess liver function test as a follow-up. An orbital radiotherapy, this is a second line therapy indication as like intravenous corticosteroid, but as if the patient cannot tolerate the high dose of corticosteroid, orbital radiotherapy is an alternative, but we can combine both radiotherapy and glucocorticoid and the results are more effective. Another drug that can be used for Graves orbitopathy is rituximab. Rituximab is a monoclonal antibody directed against beta cell C20, which is used in Hodgkin lymphoma. And this will induce a fall in TSH receptor antibody, which has a pathogenesis in the Graves orbitopathy. But this is not the first line. This is not the second line. This is the third line or the last line. Another drug, a recent drug, which is tebrotuzumab. This is a human monoclonal antibody inhibitor of IGF-1 receptor, reducing lipoptosis. and the only drug-related adverse event by this drug is hyperglycemia. And another side effects muscle spasm, nausea, alopecia, diarrhea. So don't forget that Lebrotuzumab side effects mainly hyperglycemia. A referral to ophthalmologist in a case of Graves or Batomyces is very important. A clinical feature prompting urgent referral to ophthalmologist: unexplained drop visual acuity, reduced color vision, double vision, gaze-induced orbital pain, blurring of field of the vision, corneal opacity, restriction of the eye movement, optic disc swelling, iris visibility. The most important to memorize, because most of them is all of us can suspect them, like double vision, for example, reduced color vision. Corneal opacity is very important, restricted eye movement, unexplained drop in the visual acuity, and gaze-induced orbital pain. And this algorithm published by European Thyroid Association guidelines for Graves or Batomyces and updated version. All patients with Graves or Batomyces should restore euthyroidase, urge smoking cessation, local measurement, refer to specialists except for mildest cases. If the patient presented by mild Graves or Batomyces, in this situation, we can use selenium for 6 months, but this is done in the recent onset and mild Graves or Batomyces. If the patient have impaired quality of life, we can try intravenous glucocorticoid. All other situation, intravenous glucocorticoid is the best option. Sight-threatening diabetic optic neuropathy, intravenous glucocorticoid. Moderate to severe Graves or Batomyces, if it is active, intravenous glucocorticoid. If inactive, we can try rehabilitative surgery if needed. This is another CT scan for the retrosternal goiter showing obstruction, and in this situation, surgery is the best option. The flow volume loop is the best to determine the obstruction rather than CT. Selenium for 6 months at least, Dr. Sadia, at least for 6 months. So selenium as recommended by the guidelines, recent onset mild Graves or Batomyces, and we give it 200 microgram per day for at least 6 months. Yes, we can use it more than 6 months, but usually the most effective period in which we can give, if improved, is the 6 months. If within the 6 months no improvement, don't suspect that if you use it more than 6 months, there is improvement. I don't think so, Dr. Khalid. Dr. Khalid Wafik asked about, is selenium cause hyperthyroidism? I think no. And actually, there is a very important lecture presented by Prof. Dr. Aliya Al-Ajhouri from Alexandria in the Thyroalex and Egyptian Thyroid Association conference in this year about the use of selenium in the thyroid disorders. And actually, this presentation is available already on the YouTube. So clinical presentation of thyroiditis is very important. Don't forget that subacute decurvial thyroiditis, it usually presented by tender thyroid, painful thyroid. If you see tender thyroid, ESR is elevated, anti-TPO is positive, this is a subacute decurvial thyroiditis, the only treatment required is non-steroidal anti-inflammatory drugs. Some cases require corticosteroid. Suburative or acute thyroiditis, this is a painful tender thyroid with fever. Subacute decurvial thyroiditis, generalized malaise and preceded by upper respiratory tract or viral infection in the previous 2 weeks. Radial thyroiditis, it is a hard, woody consistency of the thyroid. And this is another very important slide for the exam actually, because checkpoint inhibitor since 3 years, in each exam they will ask a question about checkpoint inhibitor. What is the most important from checkpoint inhibitor? There are two types of checkpoint inhibitor. CTLA4 inhibitor. The most important one is ipilimumab, which is used for treatment of melanoma, and PD-1 inhibitor like nivolumab, which is used for treatment of metastatic non-small cell lung cancer. So the most important, if you don't know this slide, is to know two drugs. Percentage of permanent hypothyroidism after subacute thyroiditis. Which slide, Dr. Mahawish? This slide or which one?
Checkpoint slide.
Actually, from the internet, I don't know actually, but I try to remember, but I don't know now. So the most important to know that ipilimumab, which is used for treatment of melanoma, nivolumab, which is used for treatment of metastatic non-small cell lung cancer, and also in renal cell cancer, Hodgkin lymphoma, metastatic melanoma, and so on. So this is the most important, and this actually updated in from the 4th edition of the Oxford Handbook. So ipilimumab, which is a block CTLA4, used for metastatic melanoma, and these drugs usually cause hypophysitis, central hypothyroidism, central adrenal insufficiency. So they will ask a question like, for example, a patient presented by metastatic melanoma and received ipilimumab, for example, and in this scenario, they will ask a question like, which way the patient will be presented by which disorder? Hypophysitis, central hypothyroidism, central adrenal insufficiency. If, of course, central adrenal insufficiency and central hypothyroidism, so this is a panhypothyroidism or hypophysitis. But with a nivolumab, which inhibit PD-1, and this is used for non-small cell lung cancer, renal and bladder cancer, this is usually causing thyroid dysfunction, This is usually so. Nivolumab will cause thyroid dysfunction like transient thyrotoxicosis, transient or permanent hypothyroidism, orbitopathy, Bell's thyroiditis, Rayleigh thyroid storm. The risk is about 1 to 6%. The incidence of hypothyroidism with this drug is 5 to 7%. The occurrence depends upon cycles used by this drug. And assess thyroid function and antithyroid antibody at the baseline and commence monitoring at 1 month duration. So this is very important, CTLA4 inhibitor, which is ipilimumab, and another one PD-1 inhibitor, which is nivolumab. So this is from Arab Thyroid Association Congress since a few last week, I think the previous Friday. The drugs that cause central hypothyroidism, ipilimumab, which cause hypophysitis or central hypothyroidism, and don't forget el-Maito-10. El-Maito-10, usually in each exam they will ask a question about Maito-10, either mechanism of action, side effects, and so on. So this is a very important drugs. And another important drugs presented in the 4th edition is immune reconstitutional therapy. Thyroid function occurring about 50% of people receiving this drug. This drug like الميتيزيوماب-induced thyroid function. The commonest disorder is Graves' disease, hypothyroidism, thyroiditis, and rarely Graves' disease. Also, HIV or heart patient can cause this thyroid dysfunction. Hypothyroidism is commoner than Graves' disease, both bone marrow transplantation, HSCT, probably okay. And the TSH receptor antibody play a major role. About 20% of the patient with Graves' disease exhibit fluctuating course. So don't forget that TSH receptor antibody are positive in about 70% of hypothyroid patients. And this situation, it is a blocking agent, not a stimulating agent. And the treatment of Graves' disease in this scenario, we should commence antithyroid drug after 3 months. We should reassess the patient. If the patient presented with hypothyroidism, overt hypothyroidism, we can give levothyroxine for 3 months and reassess our patient. Subclinical hypothyroidism is important in the exam. It is diagnosed by elevation of the TSH with normal thyroid hormone. When to treat, this is very important. We should repeat the sample within 2 to 3 months apart to distinguish from non-thyroidal illness. And when to treat, if TSH is more than 10, we should treat. If TSH between 4 and 10, we should treat. If the TPO antibody is positive, if there is fertility or infertility or during pregnancy, this is very important. Or there is another autoimmune disease, or the patient is symptomatic. So a treatment of subclinical hypothyroidism, when to treat, TSH is more than 10, TSH is less than 10 with anti-TPO positive, pregnancy, repeated miscarriage, repeated abortion, symptoms, or another autoimmune disorder. And in this situation, apart from a pregnancy, we should reassess our patient after 3 to 6 months. This is just a trial of levothyroxine. And also follow-up is very important. If TSH is from 4 to 10 and the patient does not have symptom, the serum TSH should be repeated annually. But if TPO is negative and the patient is subclinical hypothyroidism and no treatment is required, we should repeat TSH after 3 years. And this algorithm from European Thyroid Association guidelines, when to treat subclinical hypothyroidism. The most important for everyone, if the age is more than 70 and the TSH is less than 10, no treatment. If it TSH more than 10, we treat only elderly people if there is a symptoms consistent with hypothyroidism or high vascular risk. If the age is less than 70, we should treat if the TSH is more than 10. If the TSH is less than 10, if there is a symptoms, we should treat as a trial. If no symptoms, we should observe. But actually, as mentioned in the Oxford, if an anti-TPO is positive, if a pregnancy, repeated abortion, is another autoimmune disease, even if the patient is asymptomatic, we can do a trial of levothyroxine for 3 months. In any pregnant female already on the thyroxine, we should increase dosage of levothyroxine by 25 to 50 microgram per day, routinely. So any pregnant female receiving thyroxine, we should increase the dosage by 25 to 50 microgram. In our exam, they usually, if the TSH is more than normal, if FRT4 is low, in this situation, I will go to increase by 50 microgram per day. A combination of levothyroxine and T3. What about young children indication for treatment? If the child is symptomatic, we can treat Dr. Abdurrahman. If asymptomatic, we can postpone the treatment of this child. So a combination with levothyroxine and live-thyronine or T3 is not recommended for any case. So in any case scenario, if you see an option combination of levothyroxine and live-thyronine, don't choose this option. Yes, Dr. Abdurrahman, of course, if it TSH is more than 20 and the children we should treat, and actually this I put it in which I don't know. I will put algorithm for management of children with elevated of the TSH. Actually, this is for congenital hypothyroidism, Dr. Abdurrahman. And actually, I don't, I think this is one. I can show hypothyroidism miscellaneous. This is one. Inshallah, this is you will cover in hypothyroidism. This is from the pediatric endocrinology book. This is very important book. Actually, the third edition is very important source for neonatal congenital hypothyroidism. If TSH is more than 20, we should treat regardless of free T4. If it TSH is normal, this is a routine care. If it TSH is between 6 to 20, we follow by some sort of sex. So I will cover it later, Dr. Abdurrahman, because this is not important in the exam actually. If it, yes, Dr. Sana, I will mute someone. Dr. Sana, if TSH is in a trimester specific reference range, our target is below 2.5. Should we need to increase the dose by 25? As recommended by the guidelines, yes. We should increase the dosage by 30% actually, or 25 to 50 microgram, even if TSH is normal, because the requirement of the fetus is increased. Some doctors said the child have symptoms, but euthyroid and anti-TPO is very high, treat or not, no treatment. Even if a pregnancy, and actually I will cover it after 1 or 2 slides. So this is very important. A combination of levothyroxine and live-thyronine is not for any, not answer for any question. This is not recommended. Even if the patient receiving levothyroxine and still symptomatized by symptoms of hypothyroidism. This is a very important pituitary, because if you see this, then it, okay. This is a pituitary hyperplasia due to the chronic hypothyroidism. This is a pituitary hyperplasia due to the chronic hypothyroidism. Once we treat the patient by levothyroxine, in this situation, pituitary hyperplasia will improve. Amiodarone is very important in the exam actually, and in the exam they will ask about how to diagnose and how to treat amiodarone. The most important in newly onset amiodarone administration in the recent onset, within the first 3 months of amiodarone, TSH will be transiently increased. T3 will be decreased because the amiodarone will inhibit the conversion of T4 to T3. And the T4 will modest increase. After 3 months, TSH will be normalized with mild elevation, mild decrease of the T3 and mild elevation of the T4. How to follow up any patient receiving amiodarone? At the baseline, we should do TSH, T4, and T3. After 3 months, we do the 3 thyroid function tests. Later on, every 3 to 6 months, we should do TSH. If TSH is elevated, so this is amiodarone-induced hypothyroidism. If TSH is low, this is amiodarone-induced thyrotoxicosis. How to differentiate between type 1 and type 2 amiodarone-induced thyrotoxicosis is very important in the exam. The most common is type 2. It represents about 90%. Of course, type 1, usually there is underlying thyroid pathology, but in the type 2, there is normal thyroid, underlying thyroid pathology, normal thyroid ultrasonography, no thyroid autoantibody. The current flow Doppler in the type 1 increase vascularity, but in the type 2 absent hypervascularity. So radioactive iodine uptake will low or normal or increase for type 1, but in the type 2 suppressed, very low. So this is very important. Radioactive iodine for type 1 is very low uptake, but in the type 1 may be low or normal or increased. Suppressed, near zero in type 2. Thyroid autoantibody usually is positive for type 1, but it is usually negative in type 2. The onset time after starting the drug is short, but in type 2 is long. Spontaneous remission in the type 1 is no remission. So in this situation, after treatment by carbimazole, most cases require surgery or radioactive iodine ablation. But in the type 2, usually remission will occur after treated by corticosteroid. The patient will remit and no relapse in most cases. Subsequent hypothyroidism, no in type 1, but possible occur in the type 2. Don't forget that color flow Doppler sonography and thyroid radioactive iodine uptake is the most important investigation to differentiate between type 1 and type 2. Color flow Doppler sonography and thyroid radioactive iodine ablation, the most important tools to differentiate between type 1 and type 2. So in this situation, if you have a patient presented by amiodarone-induced hypothyroidism, treat or not to treat. The first one, if TSH is more than 20, we should treat. If the patient presented by overt hypothyroidism, TSH is, for example, 8, and Lefrito-4 is low, in this situation, we should treat. But if TSH is between 5 and 20, we can treat if the patient is symptomatic. And in this situation, it is a trial of treatment by levothyroxine. But if the patient is asymptomatic, and no underlying pathology, thyroid pathology, we cannot just observe. And this is actually manifested in this algorithm, and this algorithm from the European Thyroid Association. If amiodarone-induced hypothyroidism and the patient presented by underlying pathology chronic autoimmune thyroiditis, TSH is elevated, but when you do antibody, it is positive. When you do sonography, it is Hashimoto thyroiditis. In this situation, we should treat hypothyroidism by levothyroxine. If normal thyroid gland, can amiodarone be stopped or not? If it cannot be stopped and the TSH is more than 20 or less than 20 with symptoms, we should treat by levothyroxine. If we can stop amiodarone, so stop it and reassess by thyroid function test after 1 to 2 months. If still hypothyroid, we should give levothyroxine. If normal, so just a follow-up. This is how to treat amiodarone-induced hypothyroidism, which is straightforward. It is the same like subclinical, except in we treat if TSH is more than 20, not 10. Amiodarone-induced type 1, we can treat it by carbimazole, high dose of carbimazole. Most cases require potassium perchlorate in this situation, and if possible, discontinue amiodarone. And after rendering the patient euthyroid, the patient require radioiodine treatment or thyroidectomy. But in the amiodarone-induced thyrotoxicosis type 2, discontinue amiodarone if possible, and we give high dose of corticosteroid and just a follow-up. But actually in the exam, in most cases, we cannot differentiate between is it type 1 or type 2. In this situation, it is a mixed form. In this situation, we give carbimazole by high dose and we give a prednisolone by high dose. If rapid improvement of the case, in this situation, which type? Rapid improvement. Which type will be improved rapidly?
Type 2.
So
Type 2.
this is a type 2. In this situation, if rapid improvement occur, we should stop carbimazole and continue prednisolone. If no rapid improvement in this situation, if no rapid improvement, this is a type 1 amiodarone-induced thyrotoxicose, and in this situation, we should taper prednisolone to stop it and continue carbimazole. So, and this is mentioned in the guideline in this part. If in doubt, we should combine carbimazole with prednisolone in a very high dose for 2 weeks, followed by measurement of T3 as a thyroid hormone. If there is a reduction in the serum T3 by 50% compared to pre-treatment, so this is a type 2 and we should stopping the carbimazole. Prednisolone can then be continued in a tapering dose, reducing the course over 2 to 3 months because this is a type 2. If there is no change in the serum T3 level following initial treatment, prednisolone can be stopped and carbimazole is continued, as this assumption is the predominant diagnosis is amiodarone-induced type 1, which is treated by, yes, Dr. Omar, 40 milligram carbimazole and 40 milligram prednisolone. Yes. And this is the same as I mentioned previously, the guidelines were published by the ETA for the type 1 stop amiodarone if feasible. For type 2 amiodarone can be continued. Type 2 managed by corticosteroid, and in most cases remission will occur, but in type 1 antithyroid drug with sodium perchlorate, the patient rendered euthyroid and then go to the definitive treatment. If we cannot differentiate type 1 and type 2, it is a mixed form. We can combine antithyroid drug with corticosteroid. Just for initially, doctor, the follow-up by T3 initially. But actually, the follow-up of any case of thyrotoxicose should be by T4 and T3. But the more drug to be normalized in the amiodarone-induced thyrotoxicose is T3.
Dr. Khalid,
Yes.
no role of thyroid scan in amiodarone-induced thyrotoxicosis?
Actually, thyroid scan is very important to differentiate between both conditions. And as I mentioned that by the guidelines, this is a radioactive iodine uptake, not scan. Uptake, not scan. Uptake is the most important. The uptake is low, normal, increase in type 1, but it is very low in type 2, near to be 0. And this is actual from the guidelines. Color flow Doppler sonography and thyroid radioactive iodine determination appear to be the most useful diagnostic technique in the initial assessment of the patient with Graves amiodarone-induced. And I will give you the link for the guidelines. This is the guideline published by the ETA for amiodarone in 2018. This is one, and this table is very important. This is one. And this is table from the guidelines published by the ETA about amiodarone-induced thyroid dysfunction. So I will go rapidly. But actually, a definitive treatment for type 1 by radioactive iodine needs a very long time to be effective after rendering the patient euthyroid. Yes, Dr. Abdurrahman, Doppler is superior than radioactive iodine. I am with you actually. So current flow Doppler is superior than radioactive iodine uptake. Maternal hyperthyroid disorder during pregnancy is very important actually, because you need to differentiate between three very important conditions. Hyperemesis gravidarum, which is treated by supportive treatment. This is the same picture. TSH will be low with elevation of the thyroid hormone. And when the patient presented by hydatiform mole, this is usually a severe form of hyperemesis gravidarum or severe gestational thyrotoxicosis, and in this situation, just a supportive treatment. In gestational thyrotoxicosis, this is a usually transient, and the only treatment required is propranolol. no need for thyrotoxic drug. But with Graves' disease, propranolol is effective for controlling symptoms. Antithyroid drug is very important to provide thyroxine in the first trimester. Carbimazole is teratogenic. The risk of malformation with carbimazole is 1.7, but with the propyl thyroxine is 0.9. The risk remains 1.7 for those converted from carbimazole to propyl thyroxine in the first trimester or 3 months pre-pregnancy. So the risk of teratogenicity, if the patient already conceived with the carbimazole, the same as the patient on carbimazole in the first trimester. So this is in the latest edition. Propyl thyroxine is recommended in the woman trying to conceive, but aim to have a woman stable in propyl thyroxine for at least 3 months prior to conception. If a woman conceives on carbimazole, she should continue this throughout the pregnancy, and actually this is clinically practical practice. The first time I see it in the Oxford 4th edition, Oxford Handbook. But in the exam, don't follow this. Once the patient gets pregnant, convert to propyl thyroxine. Later on, after introduction of other guidelines, we can follow this recommendation. But actually, they recommend this sentence because a risk is 1.7 for those converted from carbimazole to propyl thyroxine in the first trimester or 3 months pre-pregnancy. So they recommend conversion to propyl thyroxine pre-pregnancy by at least 3 months. Lock and replace is not recommended, and monitor thyroid function test every 4 weeks after dosage change or 6 months postpartum. Radioactive iodine is contraindicated with thyroidectomy in the second trimester. Breastfeeding and antithyroid drug carbimazole is safe in a dosage of 20 milligram or 30 milligram, actual 30 milligram. Propyl thyroxine is safe, but it is more side effects in the mother. Both drugs are secreted in the milk in the small dosage. Hyperemesis gravidarum, this is a severe vomiting with weight loss and can occur in early pregnancy, especially in the twins pregnancy. And biochemically, T3 is less commonly elevated with suppression of TSH with elevation of the free T4 or total T4 because HCG has a TSH-like effect. Diagnosis of hyperemesis gravidarum, usually hyponatremia, hypokalemia, low urea, raised hematocrit, ketonuria, metabolic hypokalemic alkalosis, and dehydration. Antithyroid drug is not required, just supportive treatment, antiemetic and fluid and vitamin. Preconception, target of TSH in during the pregnancy and the preconception, TSH is less than 2.5. Less than 2.5. And once pregnancy confirmed, urgent check thyroid function test. If not possible, increase levothyroxine dosage by 30% to ensure optimal early neurological development. Even if TSH is less than 2.5, you must suspect that TSH will be elevated later on because the daily requirement of the fetus depends mainly on the thyroxine of the mother, and the aim to render latent TSH less than 2.5. Can we take 5? Yes, Dr. Mick, I think I will finish my presentation just a few slides. I think 30 slides. If Zoom stop, we can test for 5 minutes. I think I have just 30 minutes. A subclinical maternal hypothyroidism is very important. Of course, TSH is less than 10 with normally 54. Risk of maternal complication may be increased, and also fetal complications, no constant evidence. So no evidence that it affects fetal cognitive development when TSH is less than 10. Treatment is required by thyroxine in most situations. If TSH between 4 and 10, we should treat by levothyroxine because 2 to 5% per progress to frank hypothyroidism. And this is very important actually when to treat subclinical hypothyroidism during pregnancy. As in all cases, if TSH is more than 10, we should treat. If TSH between 4 and 10, we should treat if the anti-TPO is positive. If the anti-TPO is negative, we consider treatment. If TSH between 2.5 and 4 and the TPO is positive, we consider treatment. If the anti-TPO is negative with TSH between 2.5 and 4, we should not treat. Okay? And this is very important in any patient with euthyroid. Yes?
Repeat
Yes.
and repeat.
So I will repeat it actually from the guidelines because to let it more clarified. The American Thyroid Association, and actually this is the same as the French recommendation. This algorithm for females. According to the TSH, if it TSH more than 10, we should treat by levothyroxine. If it TSH less than 2.5, no further workup, no treatment is required. If it TSH between 2.5 and 10, according to the anti-TPO. If the anti-TPO is positive and the TSH between 4 and 10, we should treat. If it TSH between 2.5 and 4, we consider a treatment. The evidence is less in this TSH. If the anti-TPO is negative and the TSH between 4 and 10, we consider a treatment. If the anti-TPO is negative and the TSH between 2.5 and 4, we should not treat.
Dr. Khalid,
Yes?
sorry, if the TSH less than 4 and T3, T4 normal, this is the euthyroid. There is this is not a subclinical hypothyroidism.
Dr. Ahmed, during the pregnancy, there is a trimester specific reference range. So in the first trimester, the normal TSH is between 0.1 to 2.4, 2.5. So the reference range during the pregnancy is different than non-pregnant female. And actually, this is the normal reference range is changed from the latest guidelines. But I want everyone to know that the reference range of TSH during the first trimester, the upper normal TSH is 2.5. In the second and third trimester, the upper normal is 3. Okay, Dr. Ahmed?
Yeah, thanks.
So in this situation, yes. Yes, Dr. Kifa Bashir, this is a thyroid with pregnancy. And this table from the American guidelines published 2017 about management of thyroid disease during pregnancy and postpartum. I will go back to our session because this is very important because it a question in the previous exam about this. In thyroid patient with anti-TPO positive, there is increased risk of miscarriage. There is increased risk of overt hypothyroidism. There is increased risk of postpartum thyroiditis. And in this situation, the Oxford Handbook mentions that low dose levothyroxine can be considered in women who are TPO positive and euthyroid and have recurrent pregnancy loss. So this is actually euthyroid means it TSH less than 2.5. Less than 2.5, because if it is set between 2.5 and 4, we all consider treatment as the guideline. But if it TSH is less than 2.5 and the anti-TPO is positive, in this situation there is a risk of miscarriage and overt hypothyroidism and postpartum thyroiditis. The Oxford Handbook mentions that treatment by levothyroxine, a small dose of levothyroxine, can be beneficial. But actually, there is a trial published since 2 years in the New England Journal of Medicine, and this is not accepted nowadays. In a patient, an euthyroid patient with a positive anti-TPO, levothyroxine has no rule. But actually, in the exam, to choose which answer is the correct one, I don't know. But if I will choose no treatment if TSH is less than 2.5 with positive anti-TPO. And actually, I put this slide in my presentation. Okay. So this is a slide which I covered since a few minutes. Isolated hypothyroxemia, in this situation, TSH is normal with low free T4. And this can be mistaken as a central hypothyroidism, actually. But is this during the pregnancy isolated hypothyroxemia? And this situation, no evidence that treatment by levothyroxine is beneficial. Postpartum thyroid dysfunction is very important. The prevalence is very important, actually, and may be presented by a hyperthyroid stage in 30% of patients, and in about 40% presented by hypothyroidism. Hyperthyroidism in the early after delivery by 2 to 3 months. Hypothyroidism usually from 4 to 6 months after delivery, and we should treat the postpartum hypothyroidism if TSH is more than 10. But if TSH between 4 and 10 and asymptomatic, no treatment. If symptomatic, in this situation, we can treat by levothyroxine for 6 to 8 weeks. The recurrence in future pregnancy of postpartum thyroiditis is 25 of the women. So the prevalence, progression, occurrence of recurrence of postpartum thyroiditis, I think in this, according to the Oxford, is 25% of the women. But actually, in the American recommendations, they mentioned that individuals who recover fully from postpartum thyroiditis have a 70% chance for developing postpartum in the age subsequent pregnancy. So the recurrence rate, is it 70 according to the American recommendation, or 25 or 30 according to the Oxford Handbook? I don't know, because in another page they mention that it is 43, and I will cover here. I think later on. And this is a previous. Yes.
When we start L-thyroxine in patient postpartum hypothyroidism?
Overt or subclinical?
Subclinic. No, postpartum thyroid dysfunction.
If the patient presented postpartum hypothyroidism, if it TSH, it treat with levothyroxine, if it TSH is more than 10, or it TSH between 4 and 10 and symptomatic. So when to treat postpartum hypothyroidism, if it TSH is more than 10, like is subclinical, or the patient symptomatic, like is subclinical hypothyroidism, actually.
Okay, there is notes about the one question in 2021 scenario: postpartum thyroiditis, symptomatic TSH15, observe or thyroxine long term, thyroxine for 4 months, choice thyroxine long term, or what?
لا, for 4 months.
4 months.
This is just a trial for treatment, because in most cases of postpartum hypothyroidism will convert to euthyroidism after a few months. So this is just a trial by levothyroxine, because the patient is symptomatic.
Okay, thank you.
So we should wean, and they mentioned that need to recheck thyroid function test every 6 to 8 weeks and wean off thyroxine if appropriate. So this is a trial of levothyroxine, not forever. Except if postpartum thyroiditis, because in some about 25% of postpartum hypothyroidism will continue as a hypothyroidism. So they mentioned that, followed by 25 hypothyroidism and spontaneous recovery in 80% within 6 to 8 months. And permanent hypothyroidism develop in about 30 of the women within 10 years. And this is the only percentage of the people who require long-term levothyroxine, 30%. Postpartum thyroiditis, this is actually a question in the previous exam. Postpartum thyroiditis develop in 40 to 60% of the female who have anti-TPO positive. So if any pregnant female has a positive anti-TPO, the risk for development of postpartum thyroiditis is about 40 to 60%. And actually, I put this question, actually not a question. He said more than 10, we should treat Dr. Omar. Between 4 and 10, if symptomatic, we should try trial of levothyroxine. Dr. Kifah Bashir, we will go for Oxford. Okay. This is just a question, and I actually put this question because here at all book, the presence of which one of the following clinical feature has a minimal or no impact on the risk of development of postpartum thyroiditis, and they answered it in age more than 35. This is actually in the book, they answered that B is the correct one, which is not correct. In the book, they choose B as the correct one, but in the explanation, if you read the explanation, you will find that this is not a correct answer. So in the best of 5, page 99, this is not correct answer. The correct answer is A. Age has no impact on the development of postpartum thyroiditis. Actually, a risk factor for development of postpartum thyroiditis, previous postpartum thyroiditis, autoimmune disease like type 1 diabetes, systemic lupus, chronic viral hepatitis, positive anti-TPO, and the risk of development of postpartum thyroiditis in this situation is about 40 to 60%. History of previous thyroid dysfunction and family history of thyroid disease. So B is correct. This is from your book. Yes. And no, not B. Actually, Dr. A choose B. Actually, the main difference, the B is correct answer in the first edition. But in the second edition, the A is the correct one. And actually, the sorting of the options is different from first and second edition. Some question like this. In the first edition, age is number B, and the family history of thyroid function, I think, number 1.
In first edition, there is family history of thyroid dysfunction and B lymphoma.
Yes, yes. So this option is different from the first edition and second edition. In the first edition, the correct answer is B, which is lymphoma, Doctor?
Yes, lymphoma.
Yes.
And the choice P.
So please don't overlap between first and second edition of the tool book. So this is answered incorrectly in the second edition. So try to correct this. Assess all women with possible postpartum depression for thyroid dysfunction, and all women should with postpartum thyroiditis should have annual thyroid function test, and we should consider checking thyroid function in early pregnancy and postpartum, and because increasing risk of thyroid dysfunction and of course diabetic patient or another autoimmune disease previous treatment, this is drug and checkpoint inhibitor should be assess thyroid function test. The last option in my presentation today is thyroid cancer. And I hope to finish it within the next 15 minutes. So the risk factor of thyroid cancer is very important, and all of us know the most important risk factor, but I want to highlight that endemic goiter and Hashimoto's thyroiditis and obesity is another risk factor for thyroid cancer. So neck irradiation is all of us know it. Family history of thyroid cancer, Cowden syndrome, familial adenomatous polyposis, family thyroid cancer is all of us know it. But Hashimoto's thyroiditis is a risk factor for lymphoma, Endemic goiter is another risk factor for thyroid cancer. Obesity is a risk factor. And we should know that the factor that increases suspicion of malignancy if the age is less than 20, the children, or the age is more than 50, this is a risk for malignancy. So in this situation, if you have Cy2 and the patient is less than 20 or more than 50, we should repeat fine needle aspiration biopsy. If we have U2 with age less than 20 or age more than 50, we should do fine needle aspiration. Also, men is a risk factor for increasing suspicion of malignancy. Mild hypothyroidism with elevation of the TSH, risk of malignancy is increased. And other manifestation is all of us know. Favoring benign woman and associated pain or tenderness, because tenderness means thyroiditis. And how to differentiate between, of course, the most common thyroid cancer is papilla thyroid cancer, and the age of the presentation is 30 to 50, and the anaplastic is the cancer of the elderly. The papillary cancer is spread by lymphatic, but the follicular anaplastic hematogenous. So this is important. The treatment of papilla and follicular, this is a differentiated thyroid cancer treated mainly by surgery with TSH suppression or suppressive therapy and radioactive iodine ablation in high-risk patient only. But in anaplastic thyroid cancer treatment mainly by surgery with lymph node clearance at level 6 and external beam irradiation and considered chemotherapy in most cases. So surgery is the treatment of choice initially for anaplastic cancer. If we cannot do thyroidectomy, the next option is irradiation and chemotherapy. So all the treatment modality of the papillary thyroid cancer is the same for follicular thyroid cancer. Both early prognosis is very good, but for anaplastic cancer is poor. Papillary thyroid cancer and follicular thyroid cancer in the patient less than 45 age is very, very good prognosis. So if the age is less than 45, this is usually low risk of recurrence. And this oncogenes and the tumor suppressor gene for thyroid neoplasia is very important in the exam. Don't forget that for papillary thyroid cancer, BRAF gene, BRAF activation, BRAF gene is very important. And for follicular thyroid cancer, and for follicular thyroid cancer, PAX8, BPAR gamma, 1 fusion gene. Medullary thyroid cancer, all of us know that RET gene mutation. Follicular adenoma, RAS mutation. Toxic adenoma, autonomous functioning thyroid nodule, GS alpha mutation. So try to memorize at least BRAF for papillary thyroid carcinoma and RET gene for medullary thyroid carcinoma. This is the most important one. A risk stratification post surgery is very important because you will give radioactive iodine ablation and suppressive therapy. A low risk patient, this is no local or distant metastasis, all macroscopic tumor resected, no tumor invasion. In this situation, the target of the TSH is low normal. And for this patient in low risk, radioactive iodine ablation is not mandatory. So in a low risk patient, TSH target is low normal, 0.5 to 2. Not suppression, not suppressive TSH like a high risk, because a target of the TSH in the high risk patient, TSH is less than 0.1. For intermediate risk, the target of the TSH is 0.1 to 0.5. So you need to know who is the low risk, no local or distant metastasis, all macroscopic tumor has resected, no tumor invasion, and does not have aggravated histopathology. High risk extrathyroidal invasion, incomplete macroscopic, distant metastasis. In this situation, we should give suppressive therapy with target TSH is less than 0.1. Papilla microcarcinoma, this is papilla thyroid carcinoma is less than 1 centimeter, and usually the treatment required is lobectomy and no need for radioactive iodine ablation or suppressive therapy, just replacement therapy if TSH is more than 2. And I put this slide because this is an cytotoxic chemotherapy TKI1. Like sunitinib, which is used in metastatic differential thyroid cancer, and another one which is selumetinib, and the main side effects is hypertension and adrenal toxicity of this drug, which is used for metastatic differential thyroid cancer. البور prognosis in differential thyroid cancer, age is less than 10 or more than 40 years. Male gender, cellular differentiation and vascular invasion, tumor size, and tumor extent. So if there is a distant metastasis or a tumor size, for example, more than 4 centimeter, this is a poor prognosis for differential thyroid cancer, or the age is less than 10 and the male gender. And actually, this is thyroglobulin, and when to check for thyroglobulin, which is very important in the exam. Serum thyroglobulin level should be checked at least 6 weeks after the surgery to avoid the false positive results. And we should do elective radioactive iodine ablation within 3 to 6 weeks of thyroidectomy. And of course, a suppressive dose of thyroxine should be started in the 3rd day after radioactive iodine ablation, because before radioactive iodine ablation, we should stop thyroxine by 4 months, by 4 weeks. So we usually give radioactive iodine ablation 3 to 6 weeks after thyroidectomy, and the patient is not on thyroxine therapy. The suppressive dose will be started 3 days after radioactive iodine ablation, the same as 3 days restarting the carbimazole when we treat Graves' disease by radioactive iodine. The target of the TSH usually is less than 0.1, and this is especially for the high risk patient. But in the scenario, if they didn't mention the risk stratification, so you should choose the target of the TSH is less than 0.1. But if they mention the patient age and the size of the nodule and no risk, so we can choose no TSH target is more than this number. The whole body scan can be done after 9 to 12 months of radioactive iodine ablation if stimulated TG measurement is elevated, and routinely is done once and not redoing it except if there is a high suspicion of recurrence. This is another target of the TSH between 0.3 to 2 in the low risk people. And in this situation, radioactive iodine ablation is not needed, and the thyroglobulin may be secreted normally. And actually, this is the last slice from my presentation today. British Thyroid Association guidelines for TG measurement in patients with differential thyroid cancer. TSH and thyroglobulin antibody should be measured simultaneously with the serum TG, and we will assess TG only if TSH is elevated more than 30 and negative TG antibody. For patient in remission, measurement of TG and the TSH on annual basis. No need for TSH stimulation if the basal serum TG is already detectable. And this is very important, how to localize a disease recurrence. This order is very important. If you suspect recurrence of thyroid cancer, the first step is doing neck ultrasonography. If it is normal, the second step is doing CT. If it is normal, we should do whole body scan. If it is normal, we go to PET scan. So, if you suspect recurrence by rising of the TG level, the first choice in imaging localization study, we should do neck ultrasonography, then CT scan if neck ultrasonography is normal, and technetium scan if neck sonography and CT is normal. In that order, PET scan is the last correct answer. May be used if all of the previous mentioned investigation are normal. So this order is very important. How to manage medullary thyroid cancer, and actually initial evaluation, if you suspect medullary thyroid cancer by doing sonography, needle aspiration biopsy, and calcitonin level. Genetic counseling is very important because a RET oncogene mutation, a RET gene mutation analysis for diagnosis of familial medullary thyroid carcinoma. The screening for MEN2A and MEN2B is very important, and this is very important. A treatment of medullary thyroid carcinoma by total thyroidectomy with level 6 lymph node dissection. A prophylactic surgery should be considered in a disease-free, not medullary thyroid cancer, but carrier for germline RET mutation before the age of 5 years for MEN2A and before the age of 1 year in the MEN2B. This is very important. Prophylactic surgery for MEN2A before the age of 5, for MEN2B before the age of 1 year. And in both conditions, lifelong follow-up is mandatory with monitoring of calcitonin level, but don't forget that some drugs like a proton pump can falsely elevate the calcitonin. Anaplastic thyroid cancer, this is a rare thyroid cancer. The peak of incidence is 7th decade, rapidly grows, invasion, fixed tumor, aggressive tumor. Lifespan is about 6 months from diagnosis. It's treated mainly by the surgery, but in most cases, external radiation and chemotherapy is the only available option. Lymphoma, it is uncommon, almost always associated with autoimmune thyroid disease like Hashimoto's thyroiditis. So if any patient presented by Hashimoto's thyroiditis and presented by rapidly growing thyroid, suspect lymphoma, and usually this is non-Hodgkin and treated by radiotherapy and chemotherapy if more extensive, and often produce a good results. This is my last slide today. And actually, I hope boss examine the next, inshallah, all of you have a good chance to pass it easily, inshallah. And actually, I want to hint that each of you, your clinical level after studying SCE changed a lot. Your level in the endocrine is very different than 6 months ago. Yes, Dr. Omar. Dr. Omar asked about a question about familial dysalbumic hyperthyroxanemia. What is the question, Dr. Omar? Lab, I will show it, Dr. Omar, from this slide actually. But you should know that free thyroid hormone, usually free T4 is elevated with normal, in most cases actually. T3 will be normal. But in some scenarios, T3 will be elevated also. So this is a familiar dysalbumic hyperthyroxanemia. Free T4 will raised with normal free T3, but in some cases, the free T3 will be elevated also, but the TSH will be normal. And this is autoimmune, autosomal dominant condition. I will upload it. This actually I will working on it, and I will upload this session, and also I will upload its PDF immediately.
Excuse me, doctor. I ask about slide of British Thyroid Association guideline for thyroglobulin measurement in patients.
Yes, I will put it.
Yes. And last said in presence of rising thyroglobulin level.
Yes.
There are three potential
three options.
approaches.
Yes.
Yes. No action until the patient is symptomatic. What's
Yes.
mean by this?
Actually, just wait and see. And actually, in most another guidelines, they did not recommend this. Once rising TG, this means a recurrence of thyroid cancer, mostly recurrence of the thyroid cancer, and we should localize it by imaging study. And if we sure it is a recurrence, we should do empirical radioactive iodine, another dose of radioactive iodine ablation.
Okay.
If we can resect this tumor in the neck, so it is a good, but in most recurrence is metastatic thyroid cancer, so the treatment of choice for it is radioactive iodine ablation or some sort of medical treatment. Dr. Isra asked about if patients present with high TSH 18 and positive TPO who treat with thyroxine, and after 1 month the result of FRET4 come a bit high in TSH 5.8. Is that considered normally? No. This is mostly non-compliance. This is mostly non-compliance, Dr. Isra. TSH is not normalized in spite of that FRET4 is more than normal or normalized TSH. This is a picture of compliance. Also, assay interference may be give a picture like this, but in assay interference, usually TSH will be the same as pre-treatment. So this is a non-compliance. I just look for a question posted in the chat. If there is a question I can فيهم actually no, I have no time. Actually someone mentioned فيهم آخر للمراجعة شاكرين لك. It is very difficult actually. Request you to mark the correction in the PDF where you had explained error correction. Actually I do it in most mistakes in some box. I just mention it, and actually Zoom will be ended, so I will end by thank you for everyone. Zoom will shut down within 1 minute. So thanks for everyone, and I hope to see you later. And actually, I hope everyone after exam to put the questions in the exam to solve it with others. So thank you.
Thank you, Dr.
Assalamu alaikum.
Salam, Doctor.